Welcome to you all. Well, yesterday, Alexandre Demoule, who is the co-moderator for this session, and who has designed this session, basically told me, Anna, we asked you to discuss this topic because we think this is a topic where we should have an old wise man discussing this. And I told him, well, you'll see, one day you'll get gray hair too. So I do not have any specific expertise on this specific topic, even though I know this NIV topic. These are the conflicts of interest, none of which are directly related to NIV or COMA. The very first thing, I think, to discuss this type of approach would be why actually are we using NIV? Why in about 20 years this technique has been generalized in our units? There are several reasons, but one of them in particular is the fact that there are few therapy areas in ICU where we have so many randomized trials that even have given rise to many meta-analyses that show in a clear way that the NIV allow for fewer intubations and therefore less mortality in case of ARF, in case of COPD, lung edema, and hypoxemia, ARF. And also, as you know, NIV reduces mortality in patients in hospitals, which is really the case for ARF, COPD, to such an extent that if you do not offer NIV for patients with these conditions, with a pH lower than 7.35, is either a mistake or a decision of limitation of active therapy. Another indications where it might not be as clear, but it has indeed an impact on mortality, is the acute lung edema, and also a narrower indication, which is the ARF with hypoxemia in immunodepressed patients. So do not always promote this evidence-based medicine, but here we really have a high level of evidence, except that for the topic we're interested in, all of these studies have not included some patients with lack of awareness, either because of the design, because of the protocol, because the clinicians who have established the trials wanted to prove that NIV was beneficial, so they shouldn't include patients presenting a risk, that is, patients with a lack of awareness, because for these patients it can really be very important to ensure the airways working fine, or because de facto it was not included in the inclusion criteria. And de facto, they have not included patients with significant lack of awareness or consciousness problem. Here is the very first study published in Lancet, and but had not really included criteria related to consciousness. But when you look at the groups, 2 patients have not received the NIV because they were in a state of confusion and they could not cooperate. They were not comatose, simply they were in a state of confusion. So you have no patient in a state of confusion receiving NIV in this trial. A very famous trial by Laurent Brochard. This is a major paper for this technique. The criteria for exclusion, you see, a central nervous system disorder and related to hypercapnic encephalopathy. So we think, well, maybe there were some patients who got NIV while they had a severe hypercapnic encephalopathy. But when you look at the criteria, it's written very small, so you might not be able to read it. But when you look at the inclusion data, you have this encephalopathy score that was invented by Laurent Brochard for this study, and it's 1.6, 1.9. So really, they were in a little, slight state of confusion, but no patient with consciousness trouble. So we are at the very beginning. We didn't know if the technique would work, so we tried to include patients with fewer risks, which is very normal. But still, in 2000, the third major study for patients with a chronic or COPD. Well, this is the PLAN study. It's a rather specific one, a trial in neurology, not in the ICU. They wouldn't want patients with a severe disease, and here you have a Glasgow Coma Scale below 8. So even among the COPD patients in these randomized trials that are at the basis of the use of NIV, you do not have patients with a severe or clear consciousness problems. And among all of the protocols, all of the trials in the other types of ARF, even among the most prestigious one, this one published in 2002 by Gilles Hilbert, the Bordeaux team, exclusion criteria, which is absolutely reasonable, Glasgow Coma Scale of 8 or less. So this is really at the basis of the use of NIV on a daily basis. And the very first international consensus conference that we tend to forget in December 2000, it was a consensus conference where the SRLF took part. Well, no NIV for patients with a GCS under 10 and in patients who do not have the ability to cooperate. So it's very clear. Lack of awareness, low level of consciousness, no NIV. And when Alexandre Demoule, and he's here actually, when he conducted this collaborative study, it was some kind of analysis looking at what was happening in 70 units in France, and some of you might have taken part in it. With 1,076 patients, we are in 2002. The study was published in 2006. We look at the NIV use or ventilation after intubation, tracheal intubation. Well, and this is reassuring. In the ICU, fortunately, they do not use NIV when the ARF is secondary to coma. So here, this is rather reassuring. So, but we still have a critical issue to deal with, which is the best indication for NIV is ARF for COPD with hypercapnia. And one of the consequences is encephalopathy. So in severe forms of encephalopathy, there can be some lower level of consciousness. So how are we going to deal with these patients? What would be the consequence of NIV with these patients? So the level of evidence then changes. There is no randomized trial specifically on these target patients. So I'm not obsessed with the randomized trials. We have some data in the literature, but not much. The largest series, a retrospective study in MERCAT in Spain, over 5 years, going over all of the patients. They really believe in NIV, clearly, and they have 95 patients, including 2/3 of COPD patients treated with NIV, with the ARF with coma, defined as a GCS under 8, and it's an hypercapnia coma. They have excluded all other types of coma with a severe state, patients, pH 7.13, PaCO2 99, GCS 6.5, plus or minus 1.7. So what do we get? In this series, actually, the results were really extremely positive. 20% of failures, you see, with intubations and death in NIV. These patients were those for which there was a decision taken not to intubate. So 20% of failures means 80% of success for death after intubation. And overall, I would say the message is very positive. And you see here, when you analyze success and failures, there's a critical difference, which is the evolution. There's no difference in the GCS or PCO2 before NIV, but the major difference, and I think this is a major message, between success and failure is the evolution of COPD and above all of GCS going from 6.5 to 11.2 after 1 hour. 6.5 to 11.2, this is really clear with successful patients, whereas for patients in failure, it remains at around 7.9 on average after 1 hour of NIV. So the message in this study is reassuring indeed. Even if it hasn't been randomized, it's true, the success rate is very positive. So also in that study, when they have multivariate analysis of everything that is related to failure in those patients, well, what we see clearly is the SOFA maximum, which means simply that you're more and more sick, but also the evolution of the GCS after 1 hour of NIV. And I think it's a critical element. We need to remember that in clinical practice, with patients with NIV, with ARF COPD patients, we really need to assess the response to treatment in terms of consciousness. We can also follow the blood gas, pH, but what's really important is the GCS. If it goes above 11 or at 11, then this is reassuring. In truth, we have these data, very positive data, but this is not what we always get. And there is this study by the group of Stefano Nava. There is a study on a case study on the evolutions of patients treated with NIV for hypercapnia ARF with the COPD patients. They use the Kelly score that I indicated here. So at 1, it's a patient who is alert and can follow a complex comment. Grade 2 is someone who is alert, but who can really follow only simple comments. Grade 3, a lethargic patient, but a patient who is arousable and who can follow some simple instructions. 4, stuporous patients, and 5, comatose, but the brainstem is intact. And grade 6, you have a brainstem dysfunction. So they wanted to analyze all of these patients to compare the evolution of patients based upon this Kelly score when NIV was started, and with some classifications based upon age, gender, the comorbidities, HCO3, APASH3 respiratory, and also the ARF causes. And when you look at the results, actually, in terms of gas exchange and the Glasgow score for COPD, you see the various groups, Kelly 1, 2, 3, 4. And when you have a lower level of consciousness, the patients have more hypercapnia. And in all groups, after 1 hour of NIV, PaCO2 has gone down, which is normal. So we are more used to the GCS. So here the average GCS for Kelly 4 is 7, and it goes up to 10 after 1 hour. So in terms of success or failure now, it's not as positive, clearly. You have the number of patients on the first line who have met the predefined intubation criteria, 15% in Kelly 1, 25% Kelly 2, all the way to 45% in Kelly 4. So among patients who had a serious consciousness problem. And then the number of intubation in the Kelly 4, the 9 patients who had reached the intubation indication all refused to be intubated. So we do not know if they refused or the doctor didn't want to intubate. But many patients actually, and I won't discuss it right now because it will be discussed later on, some patients for whom some limitations were determined. And then you see the mortality in the hospital, 20, 35, 50%. Kelly 4, these are patients in severe condition. In the previous study, the results were very positive. Here is not so positive. So the same team has worked on another study with some control group. And here it's a study on NIV versus intubation. So patients with ARF, with COPD, with the lack of awareness. And I choose patients treated with NIV, and I compare this to a control group with patients who were intubated with a Kelly score 3 to 5, with age, gender, PCO2, pH, so 20 patients in each arm. So here we have patients who have pH that are not so much altered. You see it, it's not 710 as before. So you see the expected results. Well, there is a parallel correction, but not as fast with the NIV. And here you see the evolution of the Kelly score with the significant role of the early improvement of consciousness. And in this series, you have 7 failures out of 20. That is 35% of failures. 4 patients refused to be intubated, and there were 5 deaths in this group. And here, when you look at the curve showing the probability of being still ventilated between day 0 and day 30, you see a significant difference in favor of the NIV group. When you compare everything, patients who are intubated will take longer to be weaned from ventilation. So, and I have presented the 3 studies that specifically deal with this topic. In other studies, with the NIV for patients with severe conditions, we have a few that focus on patients with the lack of awareness, but it's really of these 3 studies, 1 observational study and 2 with a control group that shows some heterogeneous results, but basically they tell us, yes, it might work. So due to hypercapnic coma, and the critical factor is the evolution of the state of consciousness after the first hour of treatment. So in all of these trials, it was NIV with PEEP, and simply I also wanted to go back to a recent paper coming from Ecuador. And here, so ARF with COPD with a GCS under 10, we compare 2 modes of ventilation. BPAP ST is the brand name, but it's ventilatory assist with PEEP compared to AVAPS. It's with PEEP also, but with a self-titration to get to reach a goal in tidal volume. So sometimes we have this problem with the patients with lower consciousness. Shouldn't we choose a mode where we can control better the alveolar ventilation? So sometimes there are some central apnea, obstructive apnea. So it's really a small trial. But it seems that the state of awareness for these patients, this is the Glasgow score here, is improving better with this, and faster, with this technique. So I would like to go back to the conclusions of the second conference. I already mentioned the first one in 2000. Here is the second consensus conference. And given what we know today, indeed, what René Robert, who was chairing the jury, is still very relevant. So the contraindications for NIV, coma. So it would be criminal to have NIV for patients in a coma, except for hypercapnia, COPD, induced coma. And the second message that is very important, and you see it here, the criteria related to an increased failure risk, which is the fact that the lower consciousness lasts for over 2 hours after the start of NIV. So my message in conclusion would be, in case of problems of consciousness, no NIV except for the hypercapnic encephalopathy. And for these patients, we need a close monitoring with an assessment. It says the second hour, but even after 1 hour of treatment, has the state of consciousness improved? Then if we have a GCS above 11, then we can continue. Otherwise, we need to intubate the patient. Otherwise, the risk-benefit analysis is tilted towards risks. Thank you very much. And I will end with this slide. And could you guess why I chose a frog for the very last slide?
Merci beaucoup, Alain.